Good morning, everyone, and welcome. I'm Dr. Asim Hassin, and I'm glad to have you here today. Today, we're going to explore infectious emergencies, focusing specifically on intra-abdominal sepsis and source control. Over the course of this presentation, I'll walk you through the key concepts, clinical considerations, and management strategies related to these critical topics. So, let's get started and dive into this important subject together. All right, let's take a closer look at this scenario. We have a 65-year-old man with perforated sigmoid diverticulitis who is now in septic shock despite receiving fluids and antibiotics. The key question here is, what is the most important next step? Looking at the options, we need to focus on what will most effectively address his current critical condition. Escalating antibiotics alone might seem reasonable, but since he's already on antibiotics and still in shock, it suggests that the source of infection hasn't been controlled. Adding antifungal therapy is another consideration, but in this case, the primary issue is bacterial perforation leading to ongoing sepsis. Vasopressin infusion can help support blood pressure, but it doesn't directly address the source of the infection. Delaying intervention until lactate normalizes could be risky. This patient is already in shock, and waiting might worsen his condition. That leaves us with the option of urgent source control, such as surgery or drainage. This is crucial because removing or draining the source of infection is the definitive step to stop ongoing sepsis and prevent further deterioration. So, in the context of septic shock with perforated diverticulitis, the most important next step is urgent source control. This aligns with the overall theme of timely, decisive actions in managing severe infections. The correct answer here is C now. Let's talk through why. When it comes to intra-abdominal sepsis, the key to successful management is definitive source control. This means quickly identifying and controlling the source of infection. Simply relying on antibiotics alone is not enough to resolve the sepsis effectively. You need to remove or fix the underlying problem, whether that's draining an abscess or surgically repairing a perforation. This approach ensures we're not just treating the symptoms, but actually eliminating the cause of the infection. It's a critical concept that ties into the overall theme of timely and effective intervention in sepsis management. All right, let's talk about the optimal timing for source control in septic shock caused by an abdominal infection. So, when it comes to managing these patients, early intervention is crucial. The question here is, what is the best time frame to perform source control to improve outcomes? Looking at the options, we have within 72 hours, 48 hours, 24 hours, 12 hours, or as soon as feasible. The most evidence-based approach suggests that the sooner we can achieve source control, the better. Ideally, we aim for intervention within 24 hours, because delays can lead to worsening sepsis and organ dysfunction. Of course, clinical circumstances may sometimes necessitate a slightly delayed approach, but the key point is that source control should not be postponed unnecessarily. This ties back to our overall theme of prompt, decisive action in septic shock management. Early source control is a cornerstone of effective treatment, helping to reduce infection burden and improve patient survival. So, in summary, the best answer here is within 24 hours, emphasizing the importance of acting swiftly once the diagnosis is made. Correct answer is E now. Let's talk about why that's the case. Early source control, as soon as the patient is physiologically able, really makes a difference in improving survival outcomes. The key here is acting quickly, but responsibly, to control the source of the problem. When we intervene early, we can prevent the situation from worsening and give the patient a much better chance of recovery. This concept ties into the overall theme of timely and effective management. Acting promptly is often what makes the biggest difference in critical situations. So remember, the sooner we can address the source, the better the chances for a positive outcome. All right, let's look at this question about selecting the best empiric antibiotic regimen for severe intra-abdominal sepsis. As you can see, we have several options here. Ceftriaxone alone, piperacillin, tazobactam, flucloxacillin, amoxicillin, clavulanate, and metronidazole monotherapy. The key point here is that severe intra-abdominal sepsis is usually caused by a mix of aerobic and anaerobic bacteria. So, our antibiotic choice needs to cover both types effectively. Ceftriaxone is a good broad-spectrum agent against many bacteria, but doesn't reliably cover anaerobes. Flucloxacillin mainly targets gram-positive bacteria, so it wouldn't be sufficient on its own. Amoxicillin, clavulanate does cover some anaerobes, but in severe cases, we often need broader coverage. Piperacillin, tazobactam stands out because it offers broad-spectrum coverage, including many gram-negative, gram-positive, and anaerobic bacteria. This makes it particularly suitable for severe intra-abdominal infections, where we need a comprehensive approach. Metronidazole alone, while excellent against anaerobes, doesn't cover the full range of potential pathogens in this setting, especially gram-negative bacteria. So, connecting this to our overall theme, choosing the right empiric antibiotic is crucial for patient outcomes. In severe intra-abdominal sepsis, piperacillin, tazobactam is generally considered the most appropriate initial empiric therapy because of its extensive coverage. Therefore, the best answer here is B, piperacillin, tazobactam. The correct answer here is B, as indicated by the check mark. Now, let's talk through why. When selecting antibiotics for this kind of infection, it's essential to cover a broad range of bacteria. Specifically, we're looking at gram-negative organisms, which are often resistant and tricky to treat. We also need coverage for anaerobic bacteria, which can be part of these infections, and some gram-positive bacteria as well. In terms of antibiotics, options like piperacillin tazobactam, or PIP/TAZ, and carbapenems are often the go-to choices. These agents provide the broad coverage needed to effectively treat these complex infections. Remember, selecting the right antibiotic is key to ensuring we target all the likely pathogens and improve patient outcomes. This point ties into our overall theme of understanding how to choose the most effective empiric therapy based on the typical bacteria involved. All right, let's take a closer look at this question. We're asked to identify which patient is most likely to benefit from empiric antifungal therapy. Now, in clinical practice, choosing the right initial treatment depends heavily on understanding the patient's underlying condition and risk factors. Looking at these options, the key is to recognize scenarios where fungal infections are a real concern. For instance, patients with recurrent abdominal sepsis who are on total parenteral nutrition and have undergone multiple abdominal surgeries tend to have a higher risk of invasive fungal infections, especially Candida species. This makes sense because their immune defenses are often compromised, and their prolonged hospital stays or interventions increase the chance of fungal colonization and invasion. In contrast, other options like first episode of appendicitis, community-acquired cholecystitis, mild diverticulitis, or uncomplicated pancreatitis are less likely to require empiric antifungal coverage initially. So, the most appropriate choice here is the patient with recurrent abdominal sepsis, TPN, and multiple surgeries, as they are the ones who stand to benefit most from early antifungal therapy. This highlights the importance of assessing individual risk factors when considering empiric treatments, aligning with our overall theme of tailored, evidence-based care. All right, let's look at why option C is the correct answer here. When we're assessing the risk factors for candidiasis, certain features stand out as particularly significant. High-risk features include things like total parenteral nutrition, or TPN, which can disrupt the normal balance of microbes and provide a direct route for pathogens. Recurrent gastrointestinal perforations also increase the risk, as they can serve as entry points for fungi into the bloodstream. Prolonged ICU stays are another key factor because the longer a patient remains critically ill, the more they are exposed to invasive devices and broad-spectrum antibiotics, which can suppress normal flora and promote fungal overgrowth. Speaking of antibiotics, prior use of these medications is another important risk factor, as they can eliminate competing bacteria and give fungi an opportunity to flourish. So, connecting all these points, the overall picture is that these high-risk features, TPN, recurrent GI perforations, extended ICU stays, and prior antibiotics, are all associated with an increased likelihood of candidiasis. Recognizing these helps us identify patients who need closer monitoring or prophylactic strategies. Let's take a look at this question about source control. The options here can be a bit tricky, so it's important to understand the key concepts. First, we see that surgery is often considered the gold standard, but saying it's always superior to drainage isn't accurate. It depends on the situation. For example, in some cases, less invasive options like percutaneous drainage can be just as effective and safer for the patient. Now, regarding septic shock, drainage isn't necessarily avoided. It can be crucial to control the source and stabilize the patient. When antibiotics are used, source control still plays a vital role. It's not optional. Removing or controlling the source of infection helps antibiotics do their job more effectively. And about repeat interventions, it's not true that they are rarely required. Often, multiple procedures are necessary to fully control the infection. So, the most correct statement here is that percutaneous drainage is acceptable when feasible. It's a minimally invasive approach that, when appropriate, can be just as effective as surgery in controlling the source of infection. This highlights the importance of choosing the right method based on the patient's condition and the nature of the infection. Overall, effective source control is a cornerstone of managing septic patients, and tailoring our approach, whether surgical or percutaneous, is key to improving outcomes. The correct answer here is C, and I want to explain why. Percutaneous drainage is a procedure that's particularly useful when dealing with localized collections, like abscesses or fluid accumulations that are confined to a specific area. It's a minimally invasive approach, which makes it a great option compared to more invasive surgical methods. However, it's important to remember that this isn't always a one-and-done deal. Often, reassessment is necessary to ensure that the collection has been adequately drained and to check for any residual fluid. In some cases, repeat procedures might be needed to fully resolve the problem. This highlights the importance of close follow-up and monitoring in these cases to achieve the best outcomes. So, in the context of overall patient management, understanding when and how to use percutaneous drainage effectively is key to successful treatment. Let's take a closer look at some of the common causes that can lead to intra-abdominal sepsis. First, perforated diverticulitis is a major one. That's when the diverticula in the colon perforate, releasing bacteria and contents into the abdominal cavity. This can quickly escalate to infection if not managed promptly. Next, bowel ischemia, which occurs when blood flow to the intestines is compromised, leading to tissue death. This ischemia can cause perforation or necrosis, further increasing the risk of infection and sepsis. Then we have perforated viscus. That's a broader term encompassing any perforation of a hollow organ within the abdomen, like the stomach, intestines, or bladder. Such perforations allow contents to spill into the sterile peritoneal space, triggering an inflammatory response. Postoperative leaks are also significant causes. After abdominal surgery, if an anastomosis or wound doesn't heal properly, leaks can occur, releasing bacteria and fluids into the cavity. Intra-abdominal abscesses represent localized pockets of infection that can form after these events, but if they rupture or spread, they can lead to widespread sepsis. And that brings us to intra-abdominal sepsis itself, the ultimate complication where infection becomes systemic, affecting the entire body. Recognizing these causes early is crucial for timely intervention and preventing progression to severe sepsis or even septic shock. Let's take a closer look at some core principles for managing intra-abdominal sepsis. First, early antibiotics are absolutely crucial. Administering antibiotics promptly helps to control the infection before it progresses further. Next, rapid source control is essential. This means quickly identifying and addressing the source of the infection, whether that's draining an abscess or surgically removing infected tissue. Organ support in the ICU is often necessary, especially if sepsis has caused organ dysfunction. Supporting the patient's vital functions can be life-saving. And of course, ongoing reassessment is key. This includes repeat imaging as needed to monitor progress and ensure that the source control measures are effective. All of these principles are interconnected and form the backbone of effective sepsis management in intra-abdominal infections. Staying vigilant, acting swiftly, and reassessing regularly can significantly improve patient outcomes. When managing intra-abdominal sepsis, antibiotics play a crucial role. Typically, we start with broad-spectrum agents like piptazo or a carbapenem to cover a wide range of possible pathogens. If the patient is considered high risk for fungal infections, adding an antifungal agent is an important step to ensure comprehensive coverage. As we gather culture results, we should be ready to de-escalate antibiotics accordingly, narrowing therapy to target specific organisms and reduce unnecessary antibiotic exposure. This approach not only optimizes patient outcomes, but also helps in antimicrobial stewardship. So, the key points here are choosing the right initial antibiotics, considering antifungal coverage in high-risk cases, and adjusting therapy based on culture results to avoid overtreatment. All of this fits into our overall goal of effective, targeted management of intra-abdominal sepsis. Let's talk about pearls for intra-abdominal sepsis. First, it's crucial to remember that antibiotics alone do not replace source control. While antibiotics are important, they cannot fix the underlying issue, like an infected abscess or perforation. Next, delay in source control can lead to increased mortality, so timely intervention is essential. Don't think that waiting to operate is safe. Every delay can significantly worsen the patient's outcome. A common misconception is that shock contraindicates surgery. That's not true. Shock doesn't mean we should hold off on surgical intervention. In fact, prompt surgery is often necessary to control the source and stabilize the patient. Also, in cases of recurrent abdominal sepsis, Candida is quite common. So, we should be vigilant about fungal infections, especially when infections keep coming back despite antibiotics. In summary, effective management of intra-abdominal sepsis relies on prompt source control, understanding that shock shouldn't delay surgery, and being aware of fungal pathogens like Candida in recurrent cases. These are key points that tie into the overall approach to managing intra-abdominal infections successfully. Thank you so much for your time and attention. I really appreciate the opportunity to share these insights with you today. Remember, the key takeaways are about understanding the core concepts we've discussed and how they connect to the bigger picture. I hope you found this session both informative and inspiring. Please feel free to reach out with any questions or for further discussion. Thanks again for being here.